Hello everyone, where we bring you closer to India's leading doctors and share valuable insights on health, treatment options, and real patient journeys. Our goal is simple to educate, empower, and guide patients, especially from Africa, towards safe, effective, and affordable medical care in India. I am Manju Sharma. Today, we have the privilege of speaking with Dr. Shafiq Ahmed, the Urologist Director in Urology Department in BLK-Max Super Speciality Hospital in New Delhi. Dr. Ahmed is a renowned urologist with more than 18 years of experience. He specializes in treating kidney disease, prostate, and bladder conditions, kidney cancer, and also in advanced andrology treatment like infertility solutions and penile implants. He has successfully treated countless patients from Africa beyond, helping them find hope and recovery through world class treatment in India. Dr. Ahmed is a renowned urologist with more than 18 years of experience. He specializes in treating kidney disease, prostate and bladder conditions, kidney cancer, and also in advanced andrology treatments like infertility solutions and penile implants. He has successfully treated countless patients from Africa and beyond, helping them find hope and recovery through world class treatment in India. In this episode, we will be discussing some of the most common challenges related to kidney and urology health, clearing myth that often holds patients back from seeking timely care and understanding how international patients can access advanced treatment here in India. So, Dr. Ahmed, welcome to the podcast. We are delighted to have you here with us today. So, Dr. Ahmed, what is the kidney failure? Because this is my favorite topic. Uh, Having around 16, 17 years of experience in working in Africa, and most of the African patient having this same problem. And this is always coming on my mind, like what exactly the kidney failure and how it is happening to the patient.
Basically, when we say that kidney failure, it means that the kidneys cannot support our body. The main function of kidneys is to filter the blood to excrete all the toxins from the body in shape of urine and the electrolytes.
Okay.
But when the kidneys, due to any reason, whether it is due to hypertension, diabetes, or any reasons, what we will definitely subsequently discuss, fails, they cannot support the body, it means that the patient has reached to a stage where we can label him as a kidney failure.
Kidney failure.
Now, kidney failures basically are of two types. One is acute kidney failure, in which there is an injury to the kidneys due to any toxins, any infection, but these kidneys do recover. We call it as an acute kidney injury, AKI.
Infection, sorry sir, I am
Yes.
interrupting you because of I know my patient, they will ask these questions. What kind of those infections which take the kidney to get the failure?
See, kidney failure, acute kidney failure can occur because of bacterial infection, because of fungal infection, and because of viral infection also.
Right.
Any infection by any living organism can cause a kidney injury. We call as an acute kidney injury. Whenever there is a term like acute kidney injury, means that it is not a permanent damage. It is a temporary damage. These kidneys recover after certain time period. But what we are actually discussing is a chronic kidney disease or an end stage renal disease. When we say end stage renal disease, means that the function of kidney has gone down more than 15%. That means the residual function is not more than 15%, and these patients' kidney cannot sustain to function for the excretion of all the waste material from the body. We call at this stage as an end stage renal disease, or a chronic kidney disease, where the patient will definitely need some sort of support.
Okay. So does sir dialysis help for these things for the kidney failure, or what all other options are there to treat the kidney failure, sir?
Yes, so the options of treatment will definitely come, but let me first describe that what are the different reasons for some patients who can have a chronic kidney disease. Now, there are many reasons. The most common is diabetes mellitus. The diabetes is the most common worldwide, whether it is African patients, whether it is European patients, whether it is Indian or Asian patients, the diabetes stands number one. Number two is the blood pressure, uncontrolled blood pressure. Many times the people do know that they have a high blood pressure, they ignore taking and treating the high blood pressure. So the second common is a high blood pressure. The third is there are certain autoimmune diseases like lupus nephritis. There are certain glomerulonephritis, means certain infection like simple streptococcal infection that we call as a throat infection can lead to a streptococcal glomerulonephritis.
Okay.
So these are certain diseases, chronic urinary tract infections in females, or anybody who is having some that stone diseases. If they ignore to treat these, the both kidneys can permanently get damaged. So
Okay.
these are certain reasons for chronic kidney disease.
Okay.
Now, once we have actually, come to know what exactly is the reason behind the kidney failure, then obviously these patients are subjected to the evaluation and the options for them, as you mentioned.
Yeah.
The dialysis is the first option for them. However, these patients can always look for the kidney transplant. So we have two options to treat the end-stage renal disease or a chronic kidney disease. One is dialysis,
Okay.
another is a kidney transplant.
So when the patient should realize now this is the time to get the transplant done after, because of I have seen most of the patient, they just be into the dialysis and they don't actually they are not aware when this is the time to get the transplant done.
So,
Yeah.
my take on this is that transplant is a gold standard, is the ideal treatment for majority of patients who are having end-stage renal disease. Dialysis is a optional for those patients who cannot arrange a transplant.
Okay.
Dialysis is one thing which you can say that is an interim relief for those patients to have a complications because of the kidney failure. They can undergo a dialysis. It's a temporary measure. It's not a something which is going to cure the problem.
Yeah.
The dialysis is for those patients who cannot have a donor in their family or from their near and dear. So their option number two is always dialysis. However, the ideal treatment, the gold standard is always kidney transplant. Why do I say that? Because whenever there is a kidney failure, it's not only the kidney fails, it affects your blood production, it affects your brain, it affects your heart, it affects your liver. So that's why the dialysis will only clean your blood. It will not prevent the damage of your heart, your kidney, your brain. So that's why having a new kidney is essential for patients who are having a kidney failure.
Okay. And one question is that, sir, does compatible transplant is only the option? Like we have to get the compatible donor only, and does we can do we have the other option having the incompatible donor as well?
So basically, the ideal scenario that we should do a compatible kidney transplant.
Okay.
Because the chances of rejection and the long-term kidney survival
Okay.
is very good when we have a matching blood group.
Okay.
But sometimes there are certain families in which you may not be having a compatible donor available for them. So what are the options for these patients or these families? We have certain options. The option number one is that since with the advance of science that we have understood now the complete immunology of the transplant, now we have reached to a ABO incompatible transplant also, in which we do the transplant across the blood group. That means the B can give to A, the A can give to a B, and subsequently across the many other blood groups where it is not matching. However, these transplants need certain special test we call as an antibody test. We study their immunology system before the transplant, and whenever there is a requirement for to filter out the antibodies which will actually reject the kidney, new kidney, we filter them out through plasmapheresis, through immunomodulator drugs. So these transplants nowadays has equal, success rate compared to the compatible transplant. However, the word of caution is always there that since these are the costly transplant and the chances of rejections are slightly higher compared to the compatible transplant. So there are certain families who unfortunately will not have a blood group matching in their families. These are the options for them. Number two options that if still someone doesn't want to undergo a ABO incompatible transplant, they can still have a swap transplant. In swap transplant, what we exactly do, that mutually understanding in our country, especially where we follow our Human Organ Transplant Act, and where the two families can mutually exchange their donors with the respective blood groups. That means couple A has A donor and they need a B. And the couple B has a
donor.
Yes, and they require a B. So obviously they can exchange, which we call as a swap kidney transplant. And
so they should be families like a relative, or that the different patient, two patient differently, but they have the different
correct. Absolutely. And they can swap, the two families can swap their donor, to get the compatible transplant if they want to avoid the ABO incompatible transplants. So these are certain options available for us if the families doesn't have a matching blood groups.
So sir, what the success rate, if you can tell me, what the success rate between the compatible, ABO incompatible and the swap transplant patient? So what you differentiate of the success rate of all the three options?
When we talk about the success of kidney transplant, we see that how many kidneys would be working at the end of 1 year, at the end of 5 years, with respect to when they had a compatible blood, when they had incompatible blood, or they were a swap transplant. When we say swap transplant and compatible, they are almost same. At 1 year, the 95% grafts are surviving. That means after 1 year, around out of 100, 95% kidneys would be functioning. If we trace this data down the line for 5 years, approximately 80 to 85% grafts are functioning. If we trace it to 10 years, this dropped to 70 years, and around 60% of the kidney would be working even after 20 years. Now, this is the success rate of the kidney transplant. However, this is even going to improve further because of the strong immunomodulator drugs, immunosuppression drugs, which are coming up, and definitely we'll have even more success rate in the future.
That's great, sir. India is growing like anything. And sir, one thing more. So what about the advanced technology related to the kidney transplant? So what technology are we using nowadays?
If we see across the globe, in last 15 years, transplant science has extremely grown, and they are matching with the rest of the, the branches of the science as well. Rather, I would say they have progressed even more. In kidney transplant, I would speak about not only the immunology, probably I would speak about more on the surgical techniques, surgical advance in the kidney transplant. If we take example of simple gallbladder surgery, in 80s we used to remove this gallbladder by having a 10 centimeter incision. Now suddenly came out laparoscopic cholecystectomy. And nowadays, throughout the world, everyone, whether it is developing country, whether it is a developed country, the gallbladder is removed by laparoscopy. So that's the role of minimally invasive surgery. Same thing is happening in kidney transplant. Our all donors, they never undergo a knife cutting. They do not have a long incisions. They have a minimally invasive surgery, just a small incisions through which the kidney is removed, called a laparoscopic surgery. Now we have moved to the robotic kidney transplant, not the open kidney transplant.
Okay.
The same way we remove the kidney through a small 5 centimeter incision, and the same we introduce and join the kidney with the help of robot and make these patients to walk the very next morning. So this is the advance what we have come over last 15 to 20 years.
Okay.
So robotic kidney transplant is the latest addition
Okay.
to the kidney transplant surgery.
So, Dr. Ahmed, our next topic is prostate. Actually, serving in African countries, so we are getting a lot of patients' queries related to the prostate cancer and the prostate surgery. So, can you please brief about this prostate? What is the prostate actually?
So basically, prostate is a accessory sexual organ which is present only in males.
Okay.
You mentioned that why the diseases are common in African countries, and that's very true. Because all the diseases of prostate are common proportionally in the African and the Black Americans compared to the Hispanic and the Asian race.
Okay.
It has a genetic basis,
Right.
and the common diseases including BPH and the prostate cancers are very common in the American population, Black Americans and African population.
Okay.
The question was, what is prostate? It's a sexually accessory sexual organ, and it is located just below the bladder, and it surrounds the urethra. And the function of prostate is to secrete an enzyme, which is a protein called PSA, and this actually liquefies the semen. So this is the function. When we are young, this is the function which is important. But as we grow older, this prostate enlarges and start enlarging, and sometimes it can turn into the cancer also. When we say it enlarge, we call this term as a BPH, and it can give you certain symptoms. So you rightly said that the diseases are common in African and the Black Americans.
Yeah. So, sir, next question is, what are the disease of men, like of prostate in men, sir?
Yeah. So as I mentioned, when we are young, there are the common disease is prostatitis. The prostatitis can be due to the infection, or it can be due to a sexually transmitted disease. But when we grow older, there are certain hormonal changes in our body, and the prostate start growing. The common disease across the world is a BPH. BPH means that a benign hyperplasia of prostate. It's a non-cancerous problem.
Okay.
And due to the the mechanical effect, it give a pressure over to the urethra, and the patients have certain symptoms we call as a BPH.
Okay.
The second common disease, as your question was, is a prostate cancer. As we were discussing, that a man has at least 8 males will suffer out of 1 million
Okay.
prostate cancer in their lifespan. So this is not a very uncommon disease. It is common, but compared to the BPH, it is a rare disease. But it is more common in African countries and the Black Americans compared to the other races.
Okay.
So the two most common diseases, one is a BPH, another is a prostate cancer.
Right. But what caused the enlarged prostate, sir? Why there is enlarged prostate? These people are having that. So can you please, there is any reason?
As I mentioned that as we grow in our age, there are a lot of many hormone changes in the body. The testosterone component reduces,
Okay.
and due to the fat deposition, the estrogen component goes high.
Okay.
This is one reason, one theory which has been populated, that which leads to the increase in the gland size, the glandular proliferation, which can lead to the BPH.
Okay.
But cancer has its own the reason behind, the etiology behind, the basis behind. As I said, that it can run in families. It has a genetic basis.
Okay.
High influential families do have a high incidence of prostate cancer. So it has to do something with the lifestyle also. And people who are having a high sexual activity, they can also have a higher incidence of prostate cancer also.
Okay.
So there are certain factors which have been postulated, but not necessarily that they are 100% true.
Right.
Because for the cancers, the most strong association for the prostate cancer is a genetic basis, so it runs in the families.
Families. And how common is the prostate cancer is, sir?
Yeah, compared to the BPH, it is not very common. As I said that, 8 people will suffer in 1 million.
1 million.
1 million in their lifespan.
Okay.
Lifespan can have a chances of having a prostate cancer.
Okay.
The most common disease, of course, is a BPH.
BPH, right.
Yes.
And what are the symptoms of enlarged prostate or the prostate cancer, sir? Can you please explain
Yes.
to us? Yeah.
So the prostate symptoms, when a patient comes to us and in our clinic, the most common symptoms they have is urinary symptoms.
Okay.
There are 2 types of symptoms when the patient suffers from the prostate. Is one we call as an irritative symptoms, another is a obstructive symptoms. Irritative symptoms that they have to go more frequently to pass the urine. They cannot hold the urine. They have to rush to the loo. Sometimes they can even have some leakage of urine till they reach to the washroom. The second is they have to get up during the night to pass the urine. The second group of symptoms is in obstructive symptoms. In obstructive symptoms, the urinary flow is very, very weak. The inadequate bladder emptying, they do not get satisfied that they have completely emptied their bladder.
Okay.
And in extreme conditions, they can have retention of the urine. And sometimes the patients can also present with the blood in the urine also.
Okay.
There are certain symptoms which can point that the patient can have a prostate cancer also, like somebody is having a low back pain or a bony pain or a chronic cough or chronic weight loss. These patients can point, their symptoms can be pointed or can be attributed that somebody can be having a prostate cancer. However, whether the BPH or the prostate cancer, the biggest problem in diagnosing differentiating between these 2 conditions is that both of these diseases do not have a specific symptom. So a BPH and the cancer both can have a similar symptoms.
Similar symptoms.
Correct.
Yeah, that's what I was hearing. Even the normal person sometimes feel like frequent urination and the some older age they feel like leaking on the urine because of I just remember my father things as well, but he was not having any BPH in the prostate. But sometimes the symptoms looking the same like as a normal thing, like they have to go for some investigation related to that until or unless there is no blood in urine, so they will not feel like that this is the this is the trigger that they have to go for the investigations.
Yes, that's correct, because as I said that prostate diseases does not have a specific symptom by which we can pick up that this particular man is having a BPH or a prostate cancer. These urinary symptoms can be simply due to infection. These urinary symptoms can simply due to a high blood sugars also. Sometimes the people have a high blood sugar, and these patients can also go frequently to the loo. Simply if you have any types of simple drinks, like suppose you have too much of caffeine, you have too much of alcoholic drinks, you have too much of carbonated drinks. So all these patients can have a frequent urination. That's why I said that the symptoms which we have in patients does not help us too much in diagnosing a particular disease of the prostate.
Okay.
So we need to evaluate them.
Yes.
We need to have certain evaluation for them to reach out to a diagnosis what exactly they are suffering from.
So which investigation does basic investigation, like we can do it in a regular way basis, which shows us like yes, the person is having BPH, high level of BPH or anything, sir. So can you please
Yes.
guide us some investigations?
Yes. So whenever the patient
Mhm.
who come to us with these symptoms, we always suspect that this, the most common is a BPH compared to the prostate cancer. So we start our evaluation from the very basic test. The first in the investigation, which is a simple urine test.
Okay.
We do a urine analysis, urine culture to check out whether the patient is having any infection or not. The second, which is very important and specific test, although which is not very specific for the disease specific, however, it is a specific for the prostate, which is a PSA.
Okay.
PSA is a blood test which is recommended for every male after the age of 50 to pick up prostate cancer till they attain the age of 80. So from any male who is beyond 50,
Right.
they should start doing a
PSA
PSA test.
level, enough.
So if the PSA is high, we have a high suspicion that the patient can have a the prostate cancer. However, this PSA does not only increase in prostate cancer, it increases in many other conditions also. The third test is simple uroflowmetry. It's a function of bladder, a simple function of the bladder in which we check how the stream is blocked, what is the degree of blockage, and based on that we then plan the treatment. And the last investigation which is done is a ultrasound, which will give us an assessment of our prostate size and the bladder capacity and the rest of the things.
Right.
And we make these, the idea of doing these investigation is to make the difference between BPH and the cancer.
Cancer. Okay. And what is the line of the treatment, sir, for the BPH and as well normal enlargement and prostate cancer?
Yes. Yeah. So when we evaluate our patients, and the main idea is to differentiate between the BPH and the cancers. So if we have a BPH patient, say for example, let's not talk that the patient is having cancer.
Yeah.
Let's speak that the patient is having a BPH. If the patient is having BPH, then we decide whether he is a surgical candidate or he is a patient who will benefit by medications. So when we see that he is not a candidate for medication, he is a candidate for the surgery. Nowadays we have many minimally invasive surgeries, like old traditional TURP was one which is available everywhere. And based on the size of the prostate, the age of the patient, we have nowadays coming up with the minimally invasive surgery other than the lasers. We have iTint, we have Urolift, we have Resume.
Yes.
So the patients who are young in their age, they are sexually active, they want to preserve their ejaculation, and these are the patients who can come up or have the options of treating their prostate symptoms by these minimally invasive techniques. Unlike the old traditional TURP where the patient can lose their ejaculation also.
Right.
Now the second part of the disease of prostate is a prostate cancer. Now, how we 100% will make sure that the patient is having a prostate cancer? That is the biopsy.
Okay.
Once the PSA is on the higher side, we always go the next investigation is to do an MRI of the prostate. Once the MRI is done, that actually specify the lesion or any nodule in the prostate, and then we go for the biopsy. Biopsy is a gold standard to diagnose the prostate cancer. Once the prostate cancer is diagnosed, then comes the role of a PET-CT scan. The PET-CT scan will tell us what is the stage, clinical stage at least, before planning for the surgery, what are the clinical stage of our patient. So we know that any cancer, when we diagnose, it's a stage 1, stage 2, stage 3 and stage 4. Any cancer is staged into 4 stages, and then the treatment is devised according to each and every stage. In prostate cancer, let me assure my patients that this is a cancer which is extremely slow growing. And the people who suffer this disease in the age of 70s and 80s, they do not die because of the prostate cancer. It's an extremely slow growing process. So coming back to the treatment, once we have staged the patient, then we plan for the treatment. Now the patients who is having stage 1 and stage 2 is ideal treatment is a prostatectomy.
Yes.
And it is always a robotic assisted radical prostatectomy. Now, because of the understanding of this disease, even now we have started taking up the patients who are young for the locally advanced disease. That means if a patient is having a cancer in the prostate, but it has already spreaded to the lymph nodes in the pelvis, even not in the lymph node in pelvis, even the patient who is having a disease spreaded to the at least less than 5 spots in the body anywhere outside the pelvis also, which we call as a oligometastatic disease.
Okay.
Now, because of the extreme great understanding of this disease, we have started taking up these patients for the surgery.
Okay.
There are multiple reasons of doing that.
If it is spread on other organs also, still the surgery is the good option, sir?
Yes.
Okay.
Because there is multiple reasons behind that. Number one, we have got lot of support after the surgery from the radiation colleagues, and they can give the radiation to the part where the surgery cannot help. And also the latest drugs and hormones and chemotherapy, they have come up so strongly that these patients can be cured 100% even if their disease has gone outside the prostate or even to the metastasis also. Why the surgery is important in these patients? Because the prostate is strategically located at a very crucial space where our kidneys tube are opening, and they are lying very close to the prostate.
Okay.
Now, say for example, a patient, let's take a patient who has undergone a surgery to remove the prostate tumor, and the other patient has actually not gone the surgery and refused. What exactly is going to happen in the future? Now, this patient who has got tumor removed, his cancer is out of his body, number one.
Yes.
Number two, due to the mechanical pressure, the other patient is going to suffer the blockage in the urine and the blockage in the kidney tube as well.
Yes.
So that is why their life is at risk compared to the person who has removed it.
Yes.
Although we cannot say that he is going to get 100% advantage as stage 1, but yes, even if there is lesser advantage compared to stage 1, but still it is way better to remove the prostate even in the metastatic disease also.
Okay.
Rather not a widespread metastasis, rather oligometastatic. So I was discussing that stage 1, stage 2, stage 3, the ideal choice of treatment is always a radical prostatectomy.
Prostatectomy, yeah.
So when we say radical prostatectomy means that a robot was actually invented, or I would say the robot was first used for the prostate surgery.
Okay.
So the best treatment to have for the prostate prostatectomy is always a robotic radical prostatectomy.
Okay.
Now here comes the difference. Why not the open surgery? Why radical robotic prostatectomy? Let me tell you one thing. In any cancer, we know that there is a part which is bad in the body and we have to cut and remove. But in prostate, it's not like that. In prostate, we have 3 objectives. Objective number 1, to completely remove the cancer. When we say completely remove the cancer, this can never be done with a human eye and the human hand.
Okay.
Because the prostate is located deep inside the pelvis,
Yes.
behind the bone, behind the pelvic bone. So we cannot see there, we cannot reach there. Even if we are doing an open surgery, it is totally a blind procedure. The surgeon puts his hand down in the blind, he just pull out the prostate. Now in robot, because of the robotic hands, the high definition cameras, the high magnifications, high level of mobility of the robotic hands, we can remove this prostate with a great ease.
Okay.
And you can very well understand which part you need to remove, which part you need to save.
Okay.
The second objective of this surgery is to preserve the nerve which are responsible for erection. So the magnification of robotic cameras can only help us in identifying those nerves, and then we can save it, which is not possible in the open surgery.
Okay.
The third objective in this surgery is how quickly a patient will regain his urinary continence.
Yes.
That means, is he going to be on the diapers or he will pass the urine normally? So normally, if somebody wish to pass the urine normally, so the robotic surgery is an ideal option for them, not the open surgery.
Okay. And what's the recovery time on the open surgery as well as in the radical prostatectomy?
That's a very good question, because in my series that the patients who have undergone an open surgery and the patients who have undergone a robotic surgery, although in last 10 years the robotic surgery is the only surgery which we have been performing, and before 10 years definitely we had certain experiences with the open prostatectomy as well, and the recovery is extremely smooth, and I would say that these patients are walking in the room very next morning, their catheters comes out very early, and their urine control comes back in at least 6 to 8 weeks.
Okay.
They are free of any diapers, pampers, even 6 to 8 weeks. Compared to the open kidney, prostatectomy, these patients, like in open prostatectomy, there is, if the surgery is done in a proper manner, they may recover their continence in a year time. Now you can see a patient who is recovering, early continence is high in robotic compared to the open prostatectomy. The third function is a erection function. In robotic prostatectomies, patients can start have sexual activity from 6 months onward to 1 year, and at 1 year they are completely active.
Okay.
But in open prostatectomy, this is not possible.
Right.
They may not have a sexual activity even after 1 year also.
Okay.
But the last and the most important objective for which the surgery is done is that how cleanly the surgery has been performed. There is no comparison between a robotic radical prostatectomy and an open prostatectomy. Robotic radical prostatectomy is the gold standard, is the ideal procedure to be performed for patients who are suffering from prostate cancer, not the open surgery.
Okay. So my next question, though you already have answered of my next question about the sexual life of the patient after doing the prostatectomy surgery. So you already has explained to me like the radical prostatectomy patient, can they lead their life after for the sexually they will be active between 6 months to 1 year of time.
Correct.
So does they deliver the like what it is impact on the infertility of the patients? Like,
correct.
Yeah.
So usually, there are two questions. One is how quickly they regain their sexual activity. So it all depends on the stage of the disease. That's why if we go back to the PSA test, as I said, the people who do their PSA test regularly, they pick up their disease at early stage. In early stage, we can save the erection nerves. They can regain their erection, and they can enjoy their sexual life after surgery also.
Okay.
So the people who come very late, unfortunately, to clean the disease, we have to remove the nerves as well. So these are the patients who resume their sexual activity only and only by penile implant.
Okay.
They cannot have their sexual activity, they cannot have any erection after the surgery because we have removed the nerves to control the cancers.
Okay.
The second part of the question was whether they can produce children or not. So the radical surgery means that we remove all the structures which are involved in the fertility. That means their SVs, seminal vesicle structures, are being removed, and the vas are clipped. So they cannot produce children, and however, the sexual life they can definitely have if the erection nerves have been saved during the surgery, depending on the stage of the patient. If we have removed it, there for them to enjoy their sexual life is having a penile implant, which probably will definitely speak in our next podcast.
Next topic. Okay. So, sir, next topic is erectile dysfunction. So, what is erectile dysfunction?
Yeah. So, erectile dysfunction is that when a male, there are two types of erectile dysfunctions. There's a male erectile dysfunction and a female erectile dysfunction.
Okay.
But most of the time, it is referred to a male erectile dysfunction. When a male cannot perform sexual activity, we label it as a erectile dysfunction. that means there is a erection issue, and due to this, there is definitely consequently, there can be a relation issue also. So having a normal sexual life for the couple is extremely important. So this topic is very important for the everybody whosoever is listening, that having a normal and a healthy sexual life is extremely important for a married couple.
Definitely.
So erectile dysfunction, we mostly refer a patient who cannot perform the sexual activity is called as a erectile dysfunction.
Okay. So when there is a need, that couple should get the consultation related to their erectile dysfunction and about their relationship related to
This
that.
is very
Yeah.
important question.
Yeah.
Most of the time we find very young couple not having a sexual activity due to any reason. In life there's ups and downs also, and they reach to the clinics extremely anxious that if they are having erectile dysfunction. It's not that case. When a couple cannot perform sexual activity for consistently for 6 months, we label them as having erectile dysfunction. So there is no need to evaluate any person unless until they have a long history, at least minimum of 6 months.
Okay.
Then we label them as having erectile dysfunction. The sexual cycle in anybody's life has ups and downs related to many factors. So if a couple does not have a desire to have a sexual activity for a week time, 10 days, 1 month, it doesn't matter. And they should not go for evaluation unless until the time period is approximately 6 months.
6 months.
And then they should approach to their doctor for the evaluation.
Okay. And what's the line of treatment? And the second thing is that how you configure, like the male having the erectile issue or the female is having the erectile. So how you get to know about these factors?
So basically, when we talk about the line of treatment, we need to evaluate why a couple is suffering from erectile dysfunction, why a male is suffering from erectile dysfunction. Basically, the main reason, grossly we describe into psychogenic erectile dysfunction, that there is no organic problem, but it's due to the psychological effect they are having a erection problem. The second is the patient is having a vasculogenic, means that there is a problem in the blood flow. It could be arterial flow, that means the flow to the penis is not appropriate, or there is a leak. For erection, the blood should hold in the penis, but there is a leak that we call as a penile venous leak.
Okay.
So this is called a vasculogenic. The third category is a neurogenic. In neurogenic, the sensation nerves are not appropriate, and the signals are not there. They can have erectile dysfunction. The fourth is hormonal. That means somebody is having a disturbance in the hormones, like a male has a testosterone as a sex hormones. Sometimes they may not have a adequate amount of this hormone in their blood, so they can suffer from the erection problems. The fifth is, external environmental factors. Environmental factors, that means that somebody is indulged in any drug addiction, any drug intake, and all these things can lead to adverse effect on the body. Like someone is having an alcoholic, it can affect. Someone who is extreme chain smoker can affect. Somebody who's taking prohibited drugs can have a effect on their erections. So these are certain the diseases the reasons behind the erectile dysfunction.
Even the diabetes also
Yes,
play a
the
big role.
medical diseases. There are many. When I mentioned about the drugs and diabetes is the main reason of the vasculogenic erection problem. Hypertension is another vasculogenic reasons. So diabetes and hypertension actually leads to atherosclerosis, means that there is a calcium deposits in the blood vessels which hampers the blood flow. So that's why we call it as a vasculogenic. So there are certain basic diseases behind the vasculogenic. So in overall, we just categorize into these certain types and start evaluating the patients with certain laboratory tests also.
Okay. So supposed to be there is a couple from the last 6 months they were not having any kind of the like sexual
activity.
Yes, and having the issue related to the erectile things, right, sir? So then how you evaluate them? Which investigation are you doing, or do you are they going for some of the psychologists to get these things done? Because of there are so many of factors related to
Absolutely,
this.
it's a very important question.
Yes.
The first and foremost, as we discussed, that the psychological effect is the most common.
Yeah.
Around 95% of the couples who visit to our clinic with erectile dysfunction are actually not having any organic problem. They are having a psychological effect.
Yes.
So they think what exactly is not there. So it has a negative impact on their thinking process, which leads to their sexual dysfunctions. However, 5% people can have organic issues also, as we mentioned the reasons.
Yes.
Now, how actually we evaluate them? The most common evaluation test what we mention at the beginning is to check their hormones, sexual hormones, to check their lipid profile.
Okay.
As we discussed, we check their sugars, and if after certain counseling, certain medications, they do not improve, then we go ahead with the flow. That means a penile Doppler.
Okay.
We do a Doppler to see whether there is any organic problems in the flow of the blood or not. And if there is a arterial leak or a venous leak, which is picked up on the Doppler. So this is like very simple, straightforward algorithm for the patients who are having erectile dysfunction, and we find out by these simple very tests what exactly is the reason in etiology, and then obviously go for the
line of treatment.
Yes.
So supposed to be if the patient is having organ erectile dysfunction, then what the line of treatment for that, sir?
This treatment is actually compared with a knee joint problem. So suppose a patient who is having osteoarthritis of the knee and we cannot walk. The first of all, your orthopedician try to give the medication. If you can walk with the medication, or your disease becomes better. But if your disease does not get better with the medication, then they replace your knee.
Yes.
So same principle applies to the erectile dysfunction.
Okay.
First line of treatment is always that we give them whatever disease we found. Like say for example, somebody is having a dyslipidemia. Their cholesterols are high, their sugars are not good, and we advise them and then try to manipulate with the certain drugs, certain medications to improve their erections. I would say that majority of the patients, they will benefit by the medications.
Yeah.
And as we discussed earlier, the majority of them having psychological issues, they do good. But sometimes some patients has a vasculogenic or a venous leak, and their erectile dysfunction is permanent, and they do not respond to the medication. So obviously then we have certain other options. We call them as a penile implants.
Okay.
And the same way we replace the knee, we replace the penile erection function by an implant, which we call as a penile implant. Now, in penile implant, we have different types of implants. We have malleable implants, and we have inflatable implants, or
Okay.
in a layman we call as in hydraulic implants.
Okay.
So these are the two surgical options for our patients to undergo.
So which this implant, which country made, like Indian made implant or the US, or which country made implant?
Yeah, so there are many countries who actually make, and what we are using here in our country is the most common is American brands.
American brands.
And
Okay.
we do have Indian implants also.
Okay.
And our Indian implant is also very famous across the globe. And the main important is that which patient needs a hydraulic or inflatable, and which patient needs a malleable.
Yeah.
So it all depends on the
The evaluation. Okay.
the cost of
The budget factor.
the cost of implant also takes a major decision making this thing for the implant. Malleables are not so costly; they are cheaper compared to the hydraulic.
Hydraulic.
But
Okay.
when we say that which is the best implant,
Best
if the
implant,
question
yeah.
is that, the inflatable is a very high quality implant,
Okay, which is hydraulic.
which mimics almost a normal penis.
Okay.
Like these are two cylinders basically, and which we actually introduce within the penis, and there is a reservoir, and there is small button. If somebody wish to have erection, we just press that button and the penis get erect as the normal penis, and after the sexual activity it can be deflated, and you do not feel anything hard thing inside the penis all the time.
Right.
But in malleable implants, that is the only drawback they have, that the male always feels that there is something hardness in the penis.
Penis.
However,
Okay.
the overall the rigidity is compatible between the malleable and the inflatable implants.
Okay.
So overall, I would say that if there is no issue in the cost is not a factor. Inflatable implant would stand tall among the others. Yes.
That is hydraulic, right?
Yes, hydraulic implant.
Okay. And what the normal life of the patient after the penile implants? How they live their life further?
Basically, these are not the natural erections. However, they somehow 99% they mimic like natural erections. And the female partners sometimes do have a bit of complaint,
Okay.
not having the same feeling as of now as of the natural this thing penile erection. But for a couple who were not able to perform any sexual activity, for them it is definitely the best option available as of now.
Okay.
Their life after the penile implant is almost normal as a normal couple.
Okay.
When it comes to their fertility, like whether they can
They
have
produce child or not?
produce
Yeah.
they can produce a children, they can have ejaculation as the normal couple.
Yes.
They can have a normal ejaculation.
Okay.
And they can have a children, they can have a child after the penile implant surgery as well.
So that's a major important thing, like
For a couple, yes.
for a couple.
Yes.
Okay, sir.
Thank you very much.
Thank you so
Thanks a
much
lot.
for the
Thank you.
meeting today.
Thank you.
If you or a loved one is facing any of the condition we discussed today, don't delay. Early consultation can make all the difference. Once again, a big thank you to Dr. Ahmed for his time and expertise, and the audience who are listening to us. This is Manju Sharma signing off. Until next time, stay healthy and take the first step towards healing today. Thank you.